like Amy previously said. I am a master's student at Kansas State University, which is out of Kansas. I want to thank you for allowing me to speak with you today about upper GI issues. Studies have shown that approximately 10 to 20% of the population have symptoms of acid reflux, which is a pretty high number, and 15.5 million people have been diagnosed with peptic ulcer disease. So because of these statistics, it kind of emphasizes why it's so important that we do a thorough abdominal assessment on all hospitalized patients and any clinic patients that come in complaining of abdominal issues. First topic I'm going to talk about is GERD, or gastroesophageal reflux disease. This is probably the most common upper GI problem that people complain about. GERD is usually caused because of a weakened lower esophageal sphincter, otherwise known as LES. With GERD, because that sphincter is weakened, it allows gastric acids to come back up in the esophagus, which can cause inflammation to the esophagus. This can become a chronic issue, which then can cause changes to the lining of the esophagus, which is called Barrett's esophagus. Unfortunately, if these changes continue, they can also lead to those tissues becoming cancerous. An interesting thing with GERD is that sometimes patients will come in complaining about respiratory issues, saying, I have this cough, I get these bronchospasms, things like that. Whereas at first you may be thinking something respiratory, but in the end it's actually that acid causing irritation to the lining, which causes a cough and can present itself as a respiratory issue instead of an abdominal issue. Probably the most common symptom that you're going to hear about people complaining about having GERD is heartburn. There's different medications and foods that can weaken that lower esophageal sphincter and causing these symptoms. Some of the additional symptoms can be a sour taste in the back of their throat, feeling like they have a lump sitting in the back of their throat. Some people get hoarseness to their voice. And some people get regurgitation. It can also cause chest pain. People come into the ER with complaints of chest pain, and a lot of times you have to try to figure out, is it a heart issue or is it a stomach issue? The difference being is that if it's GERD, antacids are going to help the pain, and if it was a heart issue, antacids aren't really going to do much for it. So those are kind of things that cause it. But as you can see, it can definitely cause some pain feeling in the stomach as well. Usually when people come into their doctor's office complaining of having some of those symptoms, doctors are going to start out with more conservative treatments. They're going to do lifestyle changes, maybe add some medications. If those are not successful, then they may change or go to a more invasive type thing called endoscopy, where they can look at that sphincter and many other things. Have any of you ever had or taken care of somebody with an endoscopy procedure? Yeah. It is definitely a common thing the older people get. Sometimes they have to have it. They go in for some sedation, and they have a tube that goes down their throat and is able to look at esophagus, stomach, duodenum, gives them a good picture. While they do the endoscopy, they're able to take some biopsies and do some cytology studies, which can help them look for any changes in the tissue, like the Barrett's esophagus, cancer, things like that. Okay. Now, like I said, doctors will first want to suggest some lifestyle changes. I don't know about you guys, but how many of us actually like to be told we need to make some lifestyle changes? But like Mr. Froggy tells us, time for a change. If you're having these symptoms regularly, they're definitely going to suggest making some changes. You have to think of some triggers. A lot of times they'll say, think of what foods cause you to have some of these symptoms? Are there different medications that you notice these symptoms happening after while you're taking the medications? Things like smoking, alcohol, eating late night meals or snacks can definitely increase your risk of having these symptoms. So they do suggest things like eating small, frequent meals. Don't eat too late in the evening. You want to avoid anything that causes your triggers. Avoid alcohol. Try to stop smoking. You don't want to lay down immediately after eating. You want to give your body a chance to process that food. Some people who have a lot of problems with GERD actually kind of notch up the head of their bed for nighttime. They put something under the mattress so the head of the bed is elevated, or use a number of pillows so they're kind of sleeping at an angle. And stress. Stress is also something we want to decrease, and you as nursing students know a whole lot about stress and difficulties and trying to decrease your stress levels. Unfortunately, foods that can weaken that lower esophageal sphincter, some of these that we might love, especially after Halloween, the chocolate, I know I love that, fried fatty foods, peppermint, tomatoes, things with caffeine, coffee and tea. All of these things can unfortunately make GERD symptoms worse. And then, like I said, a lot of times they'll turn to medication therapy. Probably the proton pump inhibitors and the histamine receptor blockers are the most common medications that they will use, or try after you come in complaining of the symptoms. In your Lewis books, page 934 has an excellent table that goes over the different medications that they use for GERD. It goes over mechanism of action, side effects, definitely something I recommend taking a look at, page 934. Now in the hospital, we definitely see a lot of patients who are put on some of these medications. Studies have also shown that when you are admitted to a hospital, of course your stress levels go up, which can increase your body's making of that stomach acid. And in turn, they have found that more people have ended up with ulcers from the stress of being in the hospital. So it has become standard practice for many hospitals to put people on proton pump inhibitors as a prevention of ulcers in the hospital. Where I work, we tend to put everybody on Protonix unless they have an allergy to it, just to help for that prevention. The interesting thing about proton pump inhibitors, though, is that long-term use can decrease your bone density, but for people who frequently come back into the hospital, it can also increase your risk of getting C. difficile, which is a highly contagious bacterial diarrhea, which we don't want, patients don't want. So it's just something to be aware of, that if you do have someone who is on this medication, the PPI is long-term, then you want to be a little extra cautious with them. Now, if those lifestyle changes and the medications do not do enough for the patient, sometimes they do have to go to a surgical procedures. For the acid reflux, usually the Nissen fundoplication is what they turn to, which here's kind of a picture of it. And what that surgery is working towards is strengthening that lower esophageal sphincter. They're kind of wrapping, I believe, part of the stomach around to help strengthen that. This also can be used with people who have hiatal hernias, which we'll talk about on the next slide. But the reason they do this is because there's a lot of complications that can come with having chronic GERD all the time. So we want to help prevent any of those complications. So as a little break here, we're on the fun. You guys are always worried about NCLEX questions, so I look for an NCLEX type question on this topic of GERD. The nurse is planning to teach a client with GERD about substances to avoid. Which items should the nurse include in this list? Select all that apply. We always love those all questions. A, coffee. B, chocolate. C, peppermint.
A, B, C, and D.
Alright, I'm hearing all the correct answers. Coffee, chocolate, peppermint, and fried chicken. All some of the favorite things that we may love to eat, unfortunately. Some other upper GI issues that can happen are hiatal hernias. This is where part of the stomach comes up through the diaphragm. As you can see, there's a couple of different types of hiatal hernias. Unfortunately, people who have hiatal hernias tend to regularly have GERD symptoms because of that. Hiatal hernias occur more often in women than men, unfortunately. They've also found that people who wear really tight-fitting garments who have hiatal hernias definitely have more problems with GERD because of that constriction and putting that pressure on the stomach. So unfortunately, if you have a hiatal hernia, you really shouldn't be wearing Spanx or corsets. You know, it's a huge shame.
Like jeans.
No, no tight jeans. So those are not fun issues. Another issue is gastritis, which is inflammation of the lining of the stomach. Unfortunately, gastritis, if it becomes chronic, can decrease your intrinsic factor. And intrinsic factor is a protein that the stomach cells release that help absorb vitamin B12. And vitamin B12 is important in the growth and maturation of our red blood cells. So unfortunately, if you have some chronic gastritis, you can also have some anemia that might go along with that. Another big issue of the upper GI are peptic ulcer disease. You know, ulcers can occur anywhere in the esophagus, in the stomach, in the duodenum, post-operative anastomosis sites. Any of those areas can end up with ulcers. Ulceration usually occurs because of the acidic environment in the stomach. You know, the pH in the stomach is usually 2 to 3, which is pretty acidic, and that can lead toward these ulcerations. Also, they have found, now different than GERD with ulcers, is certain types of ulcers can be caused by a bacteria called H. pylori, which was definitely exciting news when they figured that out. Ulcers can last short term, you know, heal quickly, or they can become a chronic long-term issue. Some people, unfortunately, even have problems where it becomes an intermittent, where the symptoms come back and forth throughout a lifetime. So it definitely can be something that can be bothersome for a long time. Now we talked about some causes of GERD. Now, can you make any guesses about some causes about peptic ulcer diseases? Unfortunately, some of the fun stuff that people like to partake in can also cause these ulcers. Smoking, alcohol, coffee, stress. There's different medications. As you can see, that unfortunately can also lead to ulcers with the chronic use of those. And again, that bacteria, H. pylori, is also some of those. So, unfortunately, sometimes our GI system likes to take away some of our fun. Now, there are different types of ulcers. Duodenal ulcers tend to be the most prevalent that they find. The nice part is that they are also usually caused by that bacteria. 90 to 95% of duodenal ulcers are caused by that bacteria, which makes them more easily taken care of, which is a nice thing because you can put someone on an antibiotic, PPI, and helps take care of that. So the difference is that with food, food aggravates, words I want to use, gastric ulcers usually more, where food helps alleviate some of the symptoms with duodenal ulcers. A duodenal ulcer usually occurs in kind of a younger population, 35 to 45-year-olds, whereas the gastric ulcers tend to occur in the older population. You can also have the stress-related mucosal disease, and that's where people get ulcers if they've had a severe burn, trauma, major surgery. Those kind of things, unfortunately, also cause to a leading of affecting the lining of those areas. We have some symptoms. As you can see, it definitely does not look very fun, pretty painful. It can cause a burning, gnawing pain, or either one. Depending on the location of the ulcer, the gastric ones, you eat and you tend to have symptoms pretty shortly after eating. The duodenal ulcers tend to be a few hours after eating. Both of them can cause things like loss of appetite, nausea, weight loss, bloating. And there are also some silent ulcers that you have maybe some of those other symptoms of bloating, nausea, but you don't have the pain. So it makes it a little more tricky to figure out what's going on. Again, for ulcers, endoscopy is the most accurate diagnostic tool. A lot of times they talk about it being a snake. They're going to use a tube to snake down, look at things. So this says, don't be nervous. The snake is equipped with a camera and can easily squeeze itself down into your stomach and get some great shots of whatever's going down in there. But it kind of awful, besides being a little lighthearted, it also kind of emphasizes the importance of education. Because people can imagine the wildest things when they hear, oh, this tube's going in, what does that mean? What's going to happen to me? And people don't really like that a whole lot. But the nice thing with endoscopy, again, they can do biopsies of the tissue. They can look for that H. pylori. They can look for signs of cancer. So it's definitely a very nice diagnostic tool. If people cannot have an endoscopy for whatever reason, they can also do a barium contrast study under fluoroscopy. So that's a second option. A lot of people don't like drinking. The barium contrast, though, and usually is not good tasting. Treatments for peptic ulcer disease. Like I said, when they found out that there was a bacteria, it was big news at the time, because we were like, yes, we can treat this a little more easily, because like I said, some people have ulcers that last a lifetime. So if you find something that can be treated with an antibiotic and a PPI, definitely makes you a lot more happy. For ulcers that are not caused by the bacteria, people are usually put on those PPIs or the H2 receptor blockers. Sometimes they do a combination of the two medications. Some people might use antacids as well. Maybe kind of helps short term with some of that. But again, unfortunately, we have to avoid some of the things that could cause it. The smoking, the drinking, different medications they may put on hold for a number of weeks until the ulcers have a chance to heal, or kind of alter how people are taking them. And again, stress management. Now we all unfortunately have a lot of stress in our lives, so this is a little sidebar for our own little stress management. Just a little joke. So there was an elderly gentleman, lived in Minnesota, loved to plant a potato garden every year. But he was getting older, so he writes his son, "Dear son, I'm getting too old to dig up the garden. I know how much your mom loved the potato garden every year. I wish you weren't in prison so you could help me dig up the garden. Love, Dad." The son sends back a telegraph, says, "For heaven's sakes, Dad, don't dig up the garden. That's where I hid the guns." Next morning, 4 a.m., dozen police officers storm that garden. They're digging up looking for these guns, but to no avail, no gun was found. The elderly gentleman was like, now what do I do? So he writes his son again and tells him what happened and says, "Now what am I supposed to do?" The son writes back, he said, "Go ahead and plant your potato garden. It's the best I could do to help you from here." So it's important as nurses to think of stress management too, because people do come in very stressed. If you can think of things to give them a little smile, help them laugh a little bit, we all can use a little stress management some days, which is very important. Unfortunately, peptic ulcer disease can lead to some pretty serious complications. The first one is acute exacerbation or hemorrhage. This tends to be the most common complication of peptic ulcer disease. The duodenal ulcers account for a greater percentage of ulcers that have this issue. The important thing is to watch for signs of shock with this. Low blood pressure, weak thready pulses, they can become diaphoretic, they can have a little bit of pain. The important thing is kind of prepare that you're going to do some fluid replacement. If they're going into shock, maybe quick fluid replacement. And you may also have to do some packed red blood cells replacement. The second complication is perforation. This is the most lethal, life and death situation. Usually people report that they get this sudden, severe abdominal pain. Their abdomen becomes board-like, really rigid. The perforation of gastric ulcers tend to be more lethal. There's a higher mortality rate with the gastric ulcers perforations, but we tend to see more of the duodenal ulcers perforate than the gastric ones. With the perforation, you want to watch for signs of sepsis. You're definitely going to be starting some antibiotics. You're going to get an NG tube placed right away. Again, fluid replacement, possible blood replacement, and for most people will have to go to surgery to help take care of this complication. A third complication can be a gastric outlet obstruction. Obstructions are a big thing that we see, at least where I work. We have many people come in. I can't say that 100% of them are because of ulcers, but a high percentage of them are. We do have a young gentleman, he's like in his mid-20s. The first time he came into the hospital was because he had a perforated ulcer, went to surgery. It was a long healing process. He ended up on TPN, lipids, NG tube for a long time. It took a long time to heal. Well, unfortunately, he's been back to our hospital probably at least 4 times since that surgery with obstruction. One of those times they took him back for surgery to take care of scar tissue buildup that had occurred. The other times they were able to take care of it with just an NG decompression, NPO, lots of walking. But you gotta think with patients like that, they need so much encouragement because he was becoming quite depressed, he was very frustrated, he was angry, because he felt like he was doing everything that the doctors had suggested he should do, how his diet should be, what kind of exercises should be at home, and yet he still continues to come in with these obstructions. So it's an important thing to think about. It's something that if you work on the med-surg floor, you may see on a regular basis, and education and support are definitely very, very important for people who go through this regularly. On to another fun NCLEX question about peptic ulcer disease. A patient with a history of peptic ulcer disease has presented to the emergency department with complaints of severe abdominal pain and a rigid board-like abdomen, prompting the healthcare team to suspect a perforated ulcer. Which of the following actions should the nurse anticipate? So there's one of those that should be anticipated. Which way are you guys leaning?
Okay.
You guys are good. You're listening, thank you. A is the correct answer. Providing IV fluids and an NG tube. For peptic ulcer diseases, there are also surgical therapy options. Depending on where the ulcer is, would depend on what type of surgery they may do. They can also do like the vagotomy to help decrease that gastric acid secretions. These types of surgeries can usually be done laparoscopically, ideally laparoscopically, but sometimes they do have to open up to see what they're doing. So you kind of want to be prepared for either or if you end up with a patient, are going for this type of surgery. Surgery requires a lot of teaching. Nursing, a big thing in nursing is educating our patients. Preoperatively, you want to, if you have the opportunity to see them pre-op, it's great because you can definitely give them a heads up of some things that they're going to expect when they wake up. But you want to teach them the splint because they're gonna have abdominal pain. They can use a pillow, use a blanket, use your arms if you have nothing else, but something to kind of support that abdomen with. We want to teach them about deep breathing and coughing, leg exercises, moving, that they'll most likely have an NG tube after surgery. Post-operatively, the big complications we want to prevent are pneumonia and blood clots. That's why we do a lot of those things, the deep breathing and coughing, the moving. We're going to be doing vital signs regularly. They'll be having some fluids at first, and many of them will come back with a Foley too, because we do want to closely monitor their urine output, especially depending on what type they have or how quickly the surgery needs to be done. Post-op assessment, of course you're going to be doing a lot of abdominal assessing. You're going to be looking at the dressing, listening to bowel sounds, assessing the NG. NGs sometimes can start slipping out, so it's important to note where is the NG tube, because most likely when they put it in, they'll do a chest x-ray to check for placement, so you want to know where that correct placement is. Checking pH from NGs, all those good stuff. We want to medicate our patients. Abdominal surgery is definitely very painful, and they don't want to do the deep breathing and coughing because it hurts. They don't want to walk because it hurts. So it's our job to help make sure that their pain is at a tolerable level so that they can do all these things. And you have to get comfortable with asking patients, are you passing any gas, any flatus? Did you have a bowel movement? The first time you do have a bowel movement, I need to see it. So fortunately, those are kind of fun things. Only nursing love to ask about kinds of things. People look at you like, really? Especially when you have a 20-year-old.
Yeah.
They're like, I don't want to talk to you about that. Unfortunately, some of those surgeries for peptic ulcer diseases can lead to dumping syndrome because of the removal of a large part of the stomach and the pyloric sphincter. Excuse me. Dumping syndrome can make it difficult to regulate the movement of food. It usually dumps very quickly into the small intestines. So after eating, usually 15 to 30 minutes after eating, you may get some of these symptoms. You may feel like this, where you have generalized weakness, sweatiness, heart going fast, palpitations. Some people get abdominal cramping. They're running to the bathroom quickly. Some people get some hypoglycemia issues because sugar absorbs that water and makes things move through even faster. So you want to, again, educate. Teach them to eat small, frequent meals. You want to drink your fluids separately than eating. Separate the two so you're not putting so much in your stomach at one time. You want your diet to be a low carb, moderate protein, moderate fat to kind of help slow things down. And again, definitely low sugar. Sugar makes it quite a bit worse. And you may need to rest for a short period after eating. Now, if people are educated and can learn to follow some of those guidelines, within a couple of months, their symptoms will tend to decrease. Unfortunately, a lot of those guidelines are the way that they may need to eat, potentially up to a lifetime. So they definitely want to kind of get used to that, need a lot of encouragement, a lot of support to follow that, because that can be a difficult way to go. We got one more fun and question here on dumping syndrome. A client had a gastrectomy 2 days ago. To prevent dumping syndrome, which of the following is not a component of the interventions?
Drinking fluids during meals.
Absolutely.
Soup.
Nice job. So at this point, I have 3 different case studies. And so if you guys can break into 3 different groups, what I'm going to have you do is take just a couple minutes, 5 minutes, read over your case study, and you're going to decide, is this case study describing someone with GERD, peptic ulcer disease, or dumping syndrome? So I don't know if you want to go by rows or break up.
I feel like rows are the easiest.
Okay. All right. So I'll kind of put it in the middle here. And then, guys, if you want to kind of come up as a group, we'll have you let us know, read your case study and let us know which one you guys think you have.
Right here.
Amy said she was gonna put it on.
Okay. I just.
Here's, yeah, I know, I'm sorry. I have a
I can
second
make
actually.
copies. I can make copies.
Just a second, you guys are-
You're okay with just the one? Okay. Okay.
Yeah.
Eating. Is awesome.
And smoking.
It says right here.
Cause yeah, Kurt- Start with that.
Okay, Carl, you need your.
I love my coffee.
Those are on my side. I'm not gonna lie.
Cause dumping is only
I can.
closer to home, right? Okay.
Yeah.
Bueller.
Did you read it? Yeah, I did read it, yep, and I think they're,
Just closer.
Yeah.
Every part of your stomach or water.
It covers my, like. What are the
It's pretty rough.
You know what I'm talking about?
Yeah, I tried to note it in my brain. Two teachers. Temple?
We get it.
She's, like, she doesn't give you any feedback. Kind of like Isaacson and I, like, she just reads off PowerPoint, she doesn't give you like a.
Alright, looks
But
like
people
we're
in
all
her, she
done.
might be a lot easier just to deal with.
So does this first row wanna come up and have, or have a spokesperson and can read their case study and let us know what they think they have? You can do it, have faith in you.
Presentation after presentation.
It's good practice, good practice.
Okay, so I'll read the case study and then you can tell why, okay? Well, here, you read the case study and then I'll tell them. Okay.
So we have a 34-year-old man visits a primary care clinic because his family says that his voice sounds hoarse and he finds that he needs to clear his throat often. During the initial visit, he tells you that he returned from the military service 1 year ago and his routine physical exam 6 months ago was normal. He is slightly overweight and currently smokes 1 pack of cigarettes a day and has done so for 14 years. He denies experiencing any heartburn or regurgitation, although he has upper abdominal discomfort and intermittent sensation of something stuck in the region behind the sternum. He has no family history of esophageal cancer. His hoarseness has developed over the last 2 months. So, does he have peptic ulcer, GERD, or dumping syndrome?
And we said GERD.
Very good, yes, and why? What
And
made you
well,
think that?
you know, these are all my symptoms, that's what I just told you. These are all my symptoms and I know I have it, so there you go. But, hoarse voice, clears his throat often, little overweight, smokes cigarettes, and then the discomfort in the, behind the sternum. And his hoarseness has been over the last 2 months. So, there you go.
Excellent, thank you.
Excellent job.
Yeah.
Lisa, you smoke cigarettes?
Hell no.
Oh, that's good. I was gonna say, because if you do, what are you quitting?
Not after.
Yeah, no, I've never smoked.
Yeah.
And I was kidding, I said, I am on a proton pump inhibitor, but it does not work, so.
We definitely are in the works, Anna.
Yeah, it doesn't work.
Alright, so for our case study, we had a 50-year-old female present to the clinic with complications of abdominal cramping, lightheadedness, and sweating shortly after eating. She reports that her symptoms feel worse when she eats foods that are high in sugar. She also reports that she has diarrhea after almost every meal. Patient has a history of heavy alcohol use, for which she reports that she stopped drinking 6 months ago. She also states that she has a high-stress job and works 60 hours per week.
We said that she has the dumping syndrome because a lot of her symptoms are within meal times and because of the high sugar foods, and then she has a lot of the risk factors with stressful job and history of alcohol.
That's correct?
Have the whole group back here. Our case study was a 45-year-old man presents to the clinic complaining of epigastric abdominal pain for 2 weeks. He describes it as a burning pain which is non-radiating and becomes worse after eating. He has frequent belching with bloating sensation but denies nausea, vomiting, diarrhea, constipation, or weight loss. He has tried Nalox, which does help a little. He currently smokes 1 pack of cigarettes per day and has done so for 20 years. He drinks 2 to 4 cups of coffee and 2 beers per day. We were actually a little torn on this one, but we were leaning more towards the peptic ulcer disease because, first of all, the smoking, drinking coffee and alcohol, and also because he does have the belching in the morning. And
Yeah.
that's what we're eating.
You're correct.
A
I want to thank you guys for listening to me, giving me a lot of attention, and participating in my group activity. I appreciate it.
Let's give her a hand. Okay, a couple of points I want to bring up about the Nissan fundiplication that she was talking about. And you know what that is? The Nissan fundiplication, that surgery she was talking about, where they take the stomach and they kind of